Hello, everyone, and welcome to this EMAS webinar. Thank you for joining us today. My name is Antonio Cano, and I am professor of obstetrics and gynecology at the University of Valencia, and I am the past president of the European Menopause and Andropause Society. Before we begin, we would like to thank Abbott for the support and for making this new webinar series possible. The program and the content are solely the responsibility of EMAS, the European Menopause and Andropause Society. Now, moving on the technical issues, you have entered this webinar into listen-only mode. That simply means that your microphone is muted, so we don't pick up any noise from your end. We do welcome and encourage you to submit your test questions via the questions and answers Q&A widget located in your Zoom panel. You can enter your questions at any time, and we will read them during the whole session. Additionally, this event will be simultaneously translated, and you can choose one of the following languages: Russian, Mandarin, Spanish, or Portuguese. You may select the language by clicking on the interpretation widget you will find in your Zoom panel. Finally, I remind you that we are recording today's webinar and it will be accessible on the EMAS website. I would like to thank the speakers today. The agenda we have is firstly the introduction by myself, and then we will have Professor Serge Rosenberg, who is a past president of the European Menopause and Andropause Society and the head of the Gynecologic and Obstetric Clinic at St. Peter's Hospital in Brussels, Belgium. He will address the topic of the risk for thrombosis during menopause hormone therapy. Then we have Professor Nicolas Mendoza, who is a member of the board and is professor of obstetrics and gynecology at the University of Granada in Spain. He will present a very emerging and important document, which is the eligibility criteria for menopausal hormone therapy in women with medical conditions. This is a document that will be hopefully published in the coming weeks. And then to close, we will have Professor Peter Chedraoui from the University of Quito, Ecuador, in which he will speak about the risk for other cardiovascular disease, something which is a very updated and important point now that you know that re-evaluated and there are very new interpretations about the benefits associated in the cardiovascular area by menopausal hormone therapy. Interestingly, in the discussion, we will have Dr. Eftratios Kardalas and Stavroula Benetti, who will be mentees in our webinar today. So there will be a little bit the new blood that will provide answers, and I hope that many more questions to the different areas that will be the topics of today. So nothing else. Thank you, everybody. Important to comment also that we will have the topics one after the other. There will be a sequence of the presentation, and then the debate will be at the very end all together in the order that I was mentioning, initiated by the mentees, and then we will open the debate to all the attendees using the Q&A widget that I was commenting at the initiation of my presentation. Thank you, everybody. Thank you, Abbott, and thank you, EMAS, for providing us the opportunity to address these questions so important in the area of menopausal hormone therapy. So please, Serge, take the floor, and we will listen to you.
Thank you very much. I will share my presentation now. Can you see my presentation? I hope you see.
Yes,
Can you
Serge.
see my?
Yes, 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 yes. Perfect.
Thank you very much. Okay. So it's my pleasure to discuss with you this important issue, which is the risk of thrombosis using menopause hormone therapy. Here are my disclosures, and as Antonio said, this is a sponsored lecture, but I'm responsible of the content. So what is the agenda of today? We will discuss the risk of thrombosis related to menopause hormone therapy, and we will base the results on randomized controlled trials or important observational studies. We will discuss the risk factors. I will close my, if I can you close my video? I will stop my video because, okay. Voila, maybe it will be better. So we'll discuss the risk factors, the populations, demographics, the type of regimens, the type of estrogens, the doses, the regimens, the type of progestogens, and we will see that they all have different issues. Actually, the risk factors relate to them, and we will see how that translates in clinical practice, which is actually what we need for our patients. So this data are probably very familiar to most of you. It's a slide that illustrates one of the most important results of the WHI initiative study, as you remember, and it shows actually that we were treated with estrogen, and in that case, it was conjugated estrogen, together with progestin, and in that case, it was medroxyprogesterone acetate, that this woman had an excessive risk of thrombosis and emboli, as compared to the woman who were treated in placebo. So in red, you have the active regimen, in blue, the placebo. Now, when we speak about an increased risk, often we speak about the relative risk. Probably we should use rather attributable risk and absolute risk, because it makes much more sense. In this case, it means that there were 8 more pulmonary emboli per 10,000 women year. So that means 1,000 women for 10 years. Well, there were 8 cases more of pulmonary emboli. Is that a lot? I don't think so. But if you are one of the 8, you might think it is a lot. So use rather attributable risk is more, it's probably much more practical for our patients. This is another way to illustrate that. Is also, again, the data from the WHI, but in the upper panel that you see here, this is the result. These are the results of the woman treated with conjugate estrogen and MPA versus placebo. And here you see that per 1,000 women treated for 5 years, who were between the age of 50 and 60, you had an excessive risk of 5 cases. In the lower panel, it's the women who were treated with estrogen-only therapy. So these women had hysterectomy. And you see that you had an excessive risk of 2.5 per 5,000 women year. Immediately you see that the risk is not the same when you treat a patient with estrogen alone as with estrogen and progestin. Especially so if the estrogen is conjugate estrogen and the combined regimen is conjugate estrogen combined with MPA. We'll come to that later on. This is a meta-analysis, an umbrella meta-analysis actually, which summarizes several meta-analyses and what was published last year. And what you see here again, that is there is an excessive risk of deep venous thrombosis and pulmonary emboli. On the opposite, there is a decreased risk of coronary heart disease, and that will be discussed later by another speaker. So it is something that we knew for a long period of time, already from the Nurses' Health Study, the Health Trial. Most studies provided results saying that there is a 2-fold increased risk of deep venous thrombosis. Now, this risk is especially so in the first year of treatment. And this is in opposition to other risks like breast cancer that will increase with time of use. Well, this is not the case with deep venous thrombosis and emboli. The excessive risk is probably the greatest in the first year of treatment. And I will illustrate that later, and I will explain why so. It is also much more important in women who are older, as well as those who have other risk factors, like being obese or having underlying thrombophilia, like factor V Leiden, for instance, or prothrombin gene mutation, or past history of venous thromboembolism. So in this woman, you should be cautious, and we'll come to that. Here in this study, you see that the excess of risk was the most important in women treated during the first year of treatment. And thereafter, there was a lower excess of risk. Is the risk similar for all estrogens? Well, several studies have suggested, but not all, that there is no excessive risk with transdermal estrogen. This is shown here, while there is an excessive risk with oral estrogen, as shown here. But more important, I think, the doses. And in this study, you see, for instance, this is a very important UK study where they combined actually the databases of general practitioners. And what you see here is that above, for conjugate estrogen, when the dosage is lower, the risk is lower than when the dosage is high. This is even more so when you combine estrogen with a progestin, as shown here for equine estrogens. It is also true for estradiol, but the risk with estradiol is lower than with conjugate estrogen for one side, and the other side, when you give a low dose estradiol, like 1 milligram or lower, combined with dydrogesterone, you see that you have no excessive risk, while you have an excessive risk if you give a low dose estradiol with nortestosterone. So the next question is, are all progestins the same? And I already almost answered to that question. The answer is no. Actually, many studies have shown that on one side, the risk is much lower with progesterone and dydrogesterone as compared to synthetic compounds. Why is that? Probably, to make a short story, it's because the actions are quite different pharmacodynamically, but also on the receptor. Progesterone and dydrogesterone act much more on progesterone receptors, while the others, synthetic progestins, act probably much more on glucocorticoid receptors, for instance. So here in this study, you see that there is also an increased risk in red when you combine estrogen with norpregnant derivative, synthetic progestins, and you see that it is much less so when you combine it with, there is no increased risk actually when you combine it with micronized progesterone or dydrogesterone. And this is again shown in this study. You see that, as I shown you before, the combination with estradiol and dydrogesterone does not bring an increased risk of deep venous thrombosis in the UK studies, while on the other hand, the risk was increased when combined conjugate estrogen with norgestrel. Translation in clinical practice. What should we do? Well, I would like to also discuss with you this study that appeared 1 month, 2 months ago in menopause. And it's actually, they used a data bank that is known for a long time. It's a nurses' health study data bank, and where they checked on the risk of thrombosis using also genetic data of these patients and calculating a genetic risk score, aggregating for different genetic variants, and checking whether the risk was increased and whether you had some associations between menopause hormone therapy and genetic risk. What are the results? In this study, they had 430 VTA cases. And what you see is that current users of hormone therapy had an increased risk, but I remind you that in that study, it was essentially conjugate estrogen with MPA, so which is the highest risk. And what you see also that is that the risk is higher indeed for combinations compared to estrogen only. You see also that genetic risk was associated with increased risk as one would have suspected. Now, what is important here is that the estimated thrombosis risk for 10,000 women a year for women who had an important genetic risk was about 22.5, whereas it was less than 10 for women who had a low genetic risk. So which means again that we should check for genetic risk of our patients. And this would relate to my guidelines, I would say. So you should interrogate and ask your patients whether they have a history of thrombosis. If it is the case, you should check for thrombophilia, the major thrombophilia risk being factor V Leiden, but there are others like protein S deficiency and C deficiency, for instance. You should be cautious in older patients, in women who are obese. But I remind you that menopause is an opportunity for correcting risk factors, obesity, sedentarity, and smoking. If there is an indication for menopause hormone therapy, I think that there is no reason not to prescribe it for the individual patients, but you should check the balance of risk and benefit for that patient. And for most patients who have a low risk and are less than 60 years of age, menopause hormone therapy is indicated. As I said before, check for personal and family history of deep venous thrombosis. And if you prescribe hormone therapy, favor regimens with a low risk profile, that means a low dose of estradiol or transdermal estradiol combined with micronized progesterone and dihydrogesterone, conferring a lower risk of thrombosis as compared to more synthetic progestins, because quality of life matters for our patients. Thank you very much.
Thank you, Serge. This is all an area which is always there, and there are so wonderful data that you have presented, for example, those related with the genetic risk, which is something that is really interesting. So very much important for the debate. So now let's go to the second speaker. We have Professor Nicolas Mendoza, and as I said, he will present this document, which is has been just produced by the collaboration of different scientific societies, and the title is Eligibility Criteria for Menopausal Hormone Therapy in Women with Medical Conditions. So, Nico, please take the floor.
Okay, good afternoon from Granada, a beautiful city in southern Spain. First of all, I would like to thank EMAS for inviting me to participate in this roundtable. In my turn, I would like to talk about the eligibility criteria for menopause therapy.
Sorry, Nicolas, please put in full screen your slides. Thank you so much. Start presentation, please. So we can see your slide in full screen.
Pantalla completa, Nico.
Sí, sí. Yes. I have in full screen.
Yes, sí, Nicolás, y si ves abajo en la parte derecha, puedes hacer clic en el primer icono al lado de 78.
No, I don't know. Sorry, I repeat.
Tienes que empezar la presentación para que se vea en pantalla
Sí.
completa.
Pantalla completa, eso es.
Now?
Perfect. Thank you so much.
Thank-
Sorry for the
okay.
interruption.
Okay,
That's
no
perfect.
worry. This slide, this is my medical school. At this moment, I am speaking from these windows, from which I have the privilege of seeing every day of natural monuments at Sierra Nevada, in one of the wonders of the world in front of me, the Alhambra. I am grateful for the opportunity to speak at the round table on this topic, because the Spanish Menopause Society, I am the current president, is engaged in an important project that's of creating eligibility criteria for menopause hormonal therapy, similar to those created for hormonal contraceptive. We are now in the last phase and preparing the document for publication in Maturitas. So I expect to submit this afternoon after this talk. This is the reference of the research protocol. You can see in Maturitas 21, and that's the number of systematic review register. These are the 21 participating societies, including EMAS, is a multidisciplinary project with a lot of specialists, not only in gynecology, but oncology, hematology, cardiovascular, digestive disease, etc. And that's the 9 main medical conditions analyzed. Each of them divides into several specific situations. For example, how safe is HT in women with thrombotic risk? We have analyzed women with a history of thrombosis, with thrombophilia, migraine, obesity, or age. About cardiovascular disease, the cardiovascular group, we have analyzed women with a stroke, myocardial infarction, angina, or hypertension. In the group of metabolic syndrome, we have analyzed diabetes, obesity, hyperlipidemia. About the gastrointestinal disease, we have analyzed the literature about inflammatory bowel disease, hepatitis, or cirrhosis. One of the most controversial questions was to assess the safety of NHT in women with breast cancer, intense or recurrent mortality, or in women carrying the BRCA1 or the BRCA2 marks. Also, in survival of other kind of cancer, gynecologic or other cancer, lung, colorectal, or melanoma cutaneous cancer, in our case, about recurrence and mortality. Part of this, we have analyzed the safety of NHT in smoking women, and one special review about the most important pharmacological relation with menopause hormone therapy. To unify the proposal, eligibility criteria have been defined in accordance with the World Health Organization international nomenclature. As follows: Category 1, no restriction to the use of NHT. Category 2, the benefits outweigh the risks. Category 3, the risks generally outweigh the benefits. Category 4, NHT should not be used. In all the terms, quality were classified at high, moderate, low, or very low based on several factors, for example, record bias, inaccuracy, inconsistency, or publication bias. I mentioned at the beginning of this presentation, we have come on the collaboration of the Cochrane collaboration. After the first search, we identified more than 8,000 papers. And at the end, we've full the 2,036 articles. A total of 14 systematic reviews were conducted, 3 for age, 3 for thrombosis, 2 for cardiovascular disease, 1 for digestive issues, 1 for metabolic syndrome, 2 for breast cancer, 1 for other cancer, and 1 for tobacco. Moreover, a specific 1 reviews reference to address the question of drug interaction. In addition, 32 meta-analyses were conducted, 7 for cardiovascular disease, 3 for metabolic syndrome, 9 for breast cancer, and 13 for other cancer. A few words on the safety of HRT in healthy women, depending on the women age, of the menopause hormonal therapy duration. This has also been one of the conditions studies in our project. And these are the proposed eligibility criteria. Can be said that respecting age and HT duration, menopause hormonal therapy is safe under 60 and not contraindicated in most women over 60. Similarly, there is a green light for the use of MHT in most of the medical conditions analyzed. Very, very few red light and yellow light. For example, of red light, sorry, an example of red light, MHT is not recommended in women with atherosclerotic stroke or acute hepatitis. An example of yellow light, menopause hormone therapy should not be used in women with atherosclerotic myocardial infarction, or oral MHT is not recommended in smoker women. And it's interesting to know that there are medical conditions where menopause hormonal therapy is especially beneficial, such as hypertension and diabetes. This is one of the most important issues in our project and one of the most important results with regard to possible recurrent mortality in women survivor of any kind of cancer. Green light appears in most cancer survivors, women analyzed. Only in breast cancer with positive receptor, tibolone is not recommended. With regard to possible drug interactions, in the vast majority of cases, there is no contraindication or impediment to the use of MHT. Very, very few cases of contraindication. For example, aromatase inhibitor or the use of is my last slide. We hope that with this study, all menopausal women's health professionals will have a very useful tool of decision making. We are precisely working on apps and other ways that includes all the eligibility criteria with this traffic light for menopause hormonal therapy. As I say at the beginning of my talk, I hope to submit the the paper to Maturita in this afternoon at the end of the presentation. So thank you very much for your attention. You want to know about this project and more about the result of it. Thank you.
Thank you, Nico. It is really interesting to hear those new approaches about the use of MHT, which hopefully will have an impact in the use of MHT by many women who have the necessity and probably they are not using the system or the option because of they are afraid of about safety or something related like cancer or cardiovascular disease and so on. So this is something that we will address probably later in the debate. And now our third speaker today is Professor Peter Chedraui from Quito, Ecuador, and he will address the risk for other cardiovascular disease, something which you will probably agree with me, which is terribly important in the context of our session, in which we have reviewed the risk for venous thrombosis, then the eligibility criteria for use of MHT in a broad and general view. And then we will focus on the risk for other forms of cardiovascular disease, which is not venous thrombosis. Probably you all are thinking of heart disease, for example, or cerebrovascular disease. So, Peter, please take the floor. You are muted, Peter.
Peter, now, can you hear me?
Okay, yes, perfect.
Yes, thank you, Antonio. Thank you, Nico and Serge, for this opportunity to participate in this EMAS webinar. And always continuous education is very important for EMAS, especially for the Latin American mentees. The WHI interpretation, this is, I've set up some slides thanks to Antonio. I had yesterday a very emergency yesterday, so I had to set this up, and I thank Antonio for helping me with this. Is it only an epidemiological part of the question or the issue regarding the WHI? Well, we can say that what do we observe? We observed that when the results of the WHI in 2002, which have 20 years have passed, we can see that the cumulative hazard increased for coronary heart disease and stroke increased more than 30%, as we can see, comparing one regimen of estrogen and progestin. This is very important to understand that this increase in 41% seems very high, but when you look at it in the raw and the crude numbers, it is not really, it is significant statistically, but in numbers is not very much. But this is what they found, and this is what the reason why this primary preventive study was stopped. What do we observe? There was a small but statistically significant increase in cardiovascular events, and the conclusion that the combination should not be started or continued for primary prevention of coronary heart disease. This is what the conclusions. This is why in 2002 this trial was stopped. But the various arms of other research questions continued, and we have many lessons from there on. But as these results were interpreted, the media and women and health providers changed their point of view regarding hormone therapy, menopausal hormone. As you can see, the numbers that relate to the increase of hormone therapy and cardiovascular risk are not very high, as you see, compared to placebo. It's just a difference of 11 compared to 7 or 13 compared to 7. And overall, there's an increase for the use of CEE, which is conjugated echine estrogens, which is one type of estrogen. But this had a very negative impact, not only on the prescription of CEE, but also had a negative impact on other estrogen formulations, which did not was not used in this type of study. Like, for example, estradiol or tibolone, etc. There was an increase for tibolone and other, and thereon there was an increase in the use of other alternatives due to this increase in media. As we can see in this slide, right? As compared to women who participated in the WHI trial were older women, this is what supports the timing hypothesis of the global data, indicating that the less time that women have from the menopause onset is they are at lower risk due to basically what we're going to see now, that women are, the estrogen has a positive impact on the endothelium when women are younger, compared to women who are 10 to 19 or equal or more than 20. The risk of cardiovascular cardiovascular heart disease and total mortality decreases when women are less than 10 years since menopause and treated with a hormone replacement therapy, indicating this is the timing hypothesis, which was called and is very important. And this gives this provides new insights and new recommendations, as we will see later on, after 20 years of the presentation of the results of the WHI. In this arm of the WHI trial, the coronary artery calcium scores after trial completion, as you can see, in an intention to treat analysis, women who have scores more than 0 or less than 10 and less than 11 compared to analysis restricted to participation, right? There was decreased risk for those who have less a coronary artery score. And this is just like an overview, right, of all the trials related to hormone therapy and ictus. As we can see, not only from the arms of the WHI, but also to other studies in this meta-analysis, we can see that the majority, and depending on the age of women, increase, but there's a relative findings that others decrease the risk of ictus. But this is related basically to the timing hypothesis. This means that women who are treated with hormone therapy for the primary prevention of coronary heart disease was not supposed to be in women who are older. If we use the hormone therapy and not the regimen used, the positive effects of estrogen and the natural progesterone will have definitely a positive effect on the lipids and on endothelial function. What are the weaknesses of the interpretation of the WHI? Well, statistical differences are not important. They're just numbers, but the percentage of increase is high because, as you may realize, that the numbers of women treated are high. So therefore, there is a statistical difference, but in numbers, crude numbers, it's not as much. There are alternative explanations also. What other explanations do we have? Women who are treated with this hormone therapy are not usually the ones who represent those who should be treated. Women with intense symptoms were excluded from, as you can see in this slide. The majority were in their 60s, 50s, 60s, and 70s, whereas women who should be treated, right, and could have a positive effect of the estrogen use and the progesterone use will be women who are between 40 and 50 or 55 maximum. And this is one slide explaining An unstable plaque can rupture not only due to the hormone therapy, but exposed to the right stimulus. As you can see, the lipid pool and the macrophagus, it produces the plaque in the artery. There are internal, external stresses, and there can be a rupture here, and this could cause a cardiovascular event. Here's a thrombus, which is occlusive, and there is a wall of thrombus here, over here. The relationship between age distribution and the WHI and the stage of coronary arterioschlerosis is also very important, right? As you can see, between 35 and 45, we have a fatty streak plaque here, which is small. Between 45 and 55, this plaque is further increased 10% to 20% between 55 and 59. And among women who are 60 beyond, they have a 70% a necrotic core of the plaque, which is important because these are the type of women who were treated. Effects of estrogen on natural history of atherosclerosis, besides what we'll see, the metalloproteinase action is what we can see here, that estrogen's effect on atherogenesis when the plaque or the endothelium is more or less healthy, there are benefits of estrogen on atherosclerosis. It decreases LDL oxidation, LDL binding, accumulation, and lesion progression. This decrease in cell adhesion molecules like adhesion of monocytes and macrophages, very important, and the endothelial function is increased, and there is more vasodilation. We have found in experimental studies that we have performed and we have published that in women who are younger, the secretion of nitric oxide is higher as compared to women who are older, in which, of course, we have unstable plaque and we have unhealthy endothelium. Here, potential adverse effects of estrogens on atherosclerosis and cardiovascular heart disease. Estrogen effects establishes on plaques, increasing inflammation, plaque instability, lesion progression, the expression of metalloproteinase expression, increase of the instability and rupture, and there's neovascularization and the tendency to produce a plaque hemorrhage. So the benefits of estrogen decreases once women are older and have an unhealthy vasculature. The explanations: a healthy endothelium is needed for HRT to achieve cardioprotection, of course, and the benefits of HRT are progressively reduced with the increase of atherosclerosis. This is what has been written and incited after the results of the WHI presentation in 2002. Metalloproteinase and gelatinolytic activity in human coronary heart disease is a very important issue. Here we have the plasma expression of MMP9 and gelatinolytic activity of postmenopausal women average 60 years beyond. As we see, compared to placebo-treated women, those with HRT treated have a higher expression of MMP9 and gelatinolytic activity also. But of course, remember, this is very important to understand that these are women who are treated with CCE 0.625 milligrams. This perhaps might be not the case when women are treated with estradiol and with a natural progesterone. The effect of medroxyprogesterone acetate on estrogenic protection against atherosclerosis, in the adjusted model, we can see that MPA inhibits, right, the positive effects of CCE plus medroxyprogesterone acetate on the area of the plaque increased. Effect of HRT on the incidence of vasospasm in oophorectomized rhesus monkeys. As we can see, those who are ovectomized have a higher activity of vasospasm as we compare them also to E2 and acetate medroxyprogesterone. There's a decrease if we only use estradiol alone, and if we use a natural progesterone, it's not as intense as if we add the medroxyprogesterone acetate. The explanation, for example, this issue of the statin aspirin, it stabilizes plaque from the start. There are similar usage rate at the beginning, but no information on new usage and the predictive effects of estrogen are lost if treated with statins. So what are the relevant conclusions, for example, of the NAMs? That the main indication for HRT use should be treatment of symptoms. And this correlates with women who are younger who should be treated. Progesterone should be used only for endometrial protection, and it is recommended to prescribe the appropriate progesterone. For example, natural progesterone, and use estrogen, estradiol instead of conjugated CEE. HRT should not be used for the sole purpose of primary or secondary prevention of coronary heart disease, and the data of the WHI and the HERS cannot be extrapolated to women with recent symptomatic menopause or women with early menopause. The use of lower than the standard dosage should be seriously considered. So, for example, in this meta-analysis of prospective randomized studies controlled with HRT studies, we can see for coronary heart disease, the majority indicate that there is an increase of coronary heart disease and other diseases like breast cancer. Here, there's a decrease of endometrial cancer, colorectal cancer also. There's an increase for pulmonary embolus, and there's a decrease for fractures in general. The useful message of after the WHI, HERS, and ERA, and WEST, and all the other studies and branches of the WH is the confusion and controversy that surrounds postmenopausal hormone therapy make it more important to individualize treatment. The specific objectives for each patient must be identified, and the best treatment option, the formulation, dose, and route of administration that needs the patient's goal must be selected, and this process will require time-consuming patient clinical dialogue. I thank you very much for attending this webinar, and I give the ground to Antonio so we can start questions and answers. Thank you very much.
Thank you, Peter. An excellent talk, addressing many important points related with what we have learned later about the significance of the findings in the WHI, and which harmonize quite well with what we knew about the observational studies which were published in the years in the 90s, for example, and so on. Okay, so now it's the time to start our debate. And for that, please remind that we have a first part in which we have the very active role of our mentees. Those are the doctors that are being tutored by professors within the umbrella of the European Menopause and Andropause Society. And today we have two people invited. This Dr. Cardalas, Efstratios Cardalas, and also Dr. Benetti, Stavroulas Benetti. So it's time to start this debate. And I wonder, for example, have any questions?
Hello. My name is Stavroula Benetti. I am a trainee doctor in endocrinology in Greece. First of all, I would like to thank you all for these exceptional presentations. It is a great pleasure for me as a younger doctor to learn from you. First of all, I would like to start with Professor Rosenberg and the first speech. And I would like to ask if all women should be tested for thrombophilia before starting treatment.
Excellent question. And I think probably not. So I would say that if you have no past history of thrombosis in your family or personal history, you should not start a panel of tests from a cost-benefit ratio, because you would try to find something that is quite rare. On the other hand, if you have a positive family history, that's a very different issue. And in that case, yes, the answer clearly would be to start a panel of tests. So I think you have to see also, I would go further also, if in a patient who has a history, a personal history of thrombosis, if you have no really evident cause for the thrombosis, a risk factor, there is also a reason to start to check for thrombophilia. But if the patient has had her thrombosis in a context, let's imagine that she was very obese, she had a broken leg and a cast, and she was a smoker and immobilized, and she had a thrombosis at that time, well, we have enough risk factors to explain her thrombosis. I don't think it's really necessary to check for thrombophilia. But if you have a slender woman who did a thrombosis, yes, of course, you should check for thrombophilia in that case.
Thank you, Serge. I wonder, Stratios, you have a question to address?
Yes, hello from me also. I'm an endocrinologist in Athens. Thank you for the wonderful lectures. My question has to do with menopausal hormone treatment, diabetes. In the past, we thought it's a contraindication for a diabetic woman to take MHT. That has started to change. I wonder if there is some differentiation regarding the estrogen and the progesterone regimens for women with diabetes type 1 and type 2, because I think there are few studies for type 1 diabetes women receiving MHT, and I don't know if we have some new data regarding these women. Thank you.
It all depends. It all depends. May I take I just received a paper for review in one of the journals that we are members of the editorial board, and this is a question that also is like women who have risk, but it all depends on the age, because the estrogens, and depending on which estrogen, I'm talking about specifically estradiol and natural progesterone, it has a positive effect on lipids. It has a positive effect on glucose metabolism. The question is when do you give these women? For example, if I have a woman who is diabetic, right, type 1 or type 2 or whatever, but she's young and she needs to be treated, she should be treated. But of course, the problem is will they take the medication? Because, due to these risks, and, the media has put so much input and pressure that maybe women might not be wanting to take it, or maybe the physician will not want to give it. So this has to be the issue is to carefully select women who need treatment. For example, if we have a diabetic woman who does not have symptoms, right? Well, why do I have to treat her with estrogens? We don't need to give her estrogens. If she's symptomatic and she does not want to take estrogen, right, or a regimen that might be risky, well, we have a lot of alternatives now. There's a lot of evidence, a body of evidence in research with alternatives to hormonal treatment to treat their symptoms, right? Besides, women who are diabetic and maybe hypertense can benefit also of cost-effective ways like exercise, the use of metformin, exercise, dieting, Mediterranean diet. So I would try to cover that first before I give her estrogen if she doesn't have symptoms. This is a very critical question, and I thank you for this question.
Thank you, Peter.
Yeah.
Can I add something?
Yeah, please.
Yes, it was not my talk, but since you asked a question, actually in the WHI, as you know, probably the number of new diabetes patients under the active regimen was lower than in the placebo group. That is once paradoxically. But what I want to mention is that if you look at the progestins that we use, some, as I mentioned before, have a more pronounced effect on glucocorticoid receptors. So they may have some effects on diabetes also. And it has been known for long especially with high doses medroxyprogesterone acetate that were used in the past or still for contraception, for instance, that in diabetic patients, the diabetes can be destabilized when you give high doses of those progestins. So I think that if you have a diabetic patient, I would rather suggest using a progestin that is not androgenic and that doesn't work that much on glucocorticoid receptors. I wanted to add that.
That's a very interesting point, Serge. Okay, Starola, would you like to raise any? Please.
Could I ask another question for diabetes? It was mentioned that menopausal therapy is especially beneficial in women with diabetes, but it is not recommended in women with stroke or myocardial infarction. However, we do know that diabetes is strongly associated with vascular damage and atherosclerosis. How do you explain this?
Peter, would you like to give an answer to this?
Again, the question, please. Again,
question.
Yes, of course. It was mentioned that menopausal therapy is especially beneficial for women with diabetes, but it is not recommended in women who have had a stroke or a myocardial infarction. But we know that diabetes is strongly associated with atherosclerosis and vascular damage. So I think that this is a little controversial. How do you explain that?
Well, again, I say, like I said before, it all depends. I would not give a woman who has a history of stroke, who is diabetic. Again, we would have to ask the question, the primary question: does this woman have to be treated? As I said, the recommendations after 20 years of debating with the WHI analysis is that we should treat women who need to be treated, who are symptomatic. If they are older and they're not symptomatic, we don't have to give them estradiol or give them HRT for primary or secondary prevention of these diseases, which are cardiovascular, because these women would probably have an unhealthy endothelium. So the positive effects would be women who are early on menopausal onset between the 40s and 50s, who have a healthy endothelium, and there are ways to know how the endothelium is. We now have Doppler analysis and evaluation with Doppler of the carotid and all these other indexes, which indicate in what stage they could be, at least biophysically, of atherosclerosis. And if they're symptomatic, I would give them treatment. If otherwise, if not symptomatic, I would focus on their primary disease and how to treat that disease, which goes beyond hormone therapy, which would be with the endocrinologist and, taking care of her hypertension, her glucose metabolism, glucose index, dieting, exercise, et cetera, et cetera, et cetera. More than treating. And there are alternatives, by the way, there are alternatives very good to treat only if they have hot flashes, okay?
Thank you.
Yes.
Antonio.
Thank you. Yeah.
May I ask this question? It's been to see a very interesting question. And that's
it is
one
a
of the,
very, very interesting question. Yes,
that's
indeed.
one of the most controversial issues that we have analyzed in our project. May I show in 1 minute a table? That's the table you can see when the article will be published in Maturitas, I hope, in short time. So, for example, the question of myocardial infarction have a category 3.
Nico, would you mind to increase the size of the document, because we cannot really read much of what you are presenting. Maybe if you increase the size, it is a PDF.
No.
Can't see it very well.
I'm sorry. You can see at least this table or a part of this. No.
Sorry, Nicholas, you can zoom in out. Yes, perfect. Thank you.
That's better. That's better now.
That's the sample of the use of any kind of menopause hormonal therapy in women with non-fatal acute myocardial infarction. The category is 3, but in that only in atherosclerotic myocardial infarction. In that case, with other reason and with our process that could be the theology of the infarct, the category is R2 in all cases. And a woman with diabetes without any cardiovascular disease, the eligibility criteria is in all cases 1 or 2 only for oral estrogen. Because Peter has said there are a lot of benefits of menopause hormonal therapy in this kind of patients. This is the table I want to show you because we can get it in a short time, I hope. Thank you.
Okay, Nico, thank you. I think it is important also probably to mention, because this is a question which is in everyday practice. We find women who are at higher risk, and in those cases, we shouldn't use menopausal hormone therapy. And it is a little bit paradoxical that we sustain that menopausal hormone therapy decreases the risk of diabetes, but instead we cannot use it, or we shouldn't use it whenever we face diabetic, for example, type 1 diabetic woman. So probably what we should stress, and this is something which is very much related also with the sensitivity to insulin which is induced by menopausal hormone therapy. So we know, for example, that during the change of the menopausal transition, there is an increase in the resistance to insulin and also an increase in the accumulation of fat at the central fat. And this is something which is prevented by menopausal hormone therapy, and this is probably what it is behind the data showing that the use of hormones decreases the risk of diabetes. But then, if we find women who are diabetic, and because diabetic probably they have an increased risk of cardiovascular disease and they have a certain level of atherosclerosis, this is the case in the menopausal hormone therapy, as shown, for example, by Professor Chedraoui. You may increase the activity of metalloproteinases and those enzymes which are involved in the digestion of the plaque at the level of the artery. So I think it is a very important point that it may seem a little bit paradoxical, but probably we are considering two different mechanisms of actions. One which is the reduction of risk of diabetes, and then the case of women who are already diabetic, probably they have a certain level of atherosclerosis, and because of that, we should be cautious in the use of menopausal hormone therapy. So probably this is something that may be also taken into account for that. I think we have also a question here from the very beginning from Dr. Musti, a question which was already partially answered by Nico Mendoza. And it is the use of menopausal therapy for women who have been ovariectomized because of an ovarian cancer. So this is the issue of safety of hormone therapy in women, but it's not the usual case of breast cancer, which is a little easier. It's the case of ovarian cancer. So, Nico, you already replied. I wonder if Serge or Peter, you would like to add something about the use of hormones in those ladies who are who have suffered ovarian cancer and they have been ovariectomized.
Yes, a good question. We have a very controversial comment about the first eligibility criteria for these women. Most of ovarian cancer survivors have epithelial cancer. In these cases, ovarian cancer and the American way to use HRT, oral conjugated estrogen alone or plus medroxy progesterone. An overall review of this study suggests that HRT does not modify disease evolution. And some studies even suggest that overall disease-free survivor increase in menopause hormonal therapy use. But we haven't literature about any kind of other type of cancer and other type of HRT. By expert opinion, we only put this criteria in women with survivor of epithelial cancer, not advanced epithelial cancer.
Yes.
Thank you, Nico. I wonder if you, Serge, would you like to add something?
Yes,
Peter?
thank you. I think that there is a huge difference, and I would speak both for breast cancer, because you mentioned, Antonio, also breast cancer, and I saw that in the paper of Nicolas, and I was wondering, I will come back to that in a minute, but I think that there is a huge difference between women at risk, at very high risk, even for genetic reasons, for ovarian cancer and for breast cancer. So in women who have mutations for BRCA1 and 2, or who have Lynch syndrome, for instance, and have not had suffered a cancer yet, I speak about cases with high risk, identified high risk, it is clear that the benefit of menopause hormone therapy from several studies probably is much larger than the risk. So we published that in a review paper recently. There are several other papers that go in that same direction. So in these patients should be treated with menopause hormone therapy or hormone replacement therapy, call it as you want, at least to the age of a normal menopause that is around 50. The other issue is much more controversial. And I saw that Nicolas wrote that women who have no hormone receptors in the breast, if I understood well, and who had breast cancer, could be prescribed with menopause hormone therapy. It is an interpretation of the data that I'm not that clear of, because we are on the edge with literature. It is true that the literature shows essentially an increased risk in those women with positive receptors for breast cancer. But the studies were intended to study the patient in a group. So these are sub-analyses these are ancillary studies. So I think we are on the gray zone. It is for ovarian cancer, as Nicolas said, it is true, because also there are very few data, and there are, of course, no randomized studies. And these patients with ovarian cancer often have a low survival rate. So it's very difficult to interpret it. I think in the clinical practice, what I would say is discuss it with your patient and with the oncologist, so that the patient will not be balanced between the oncologist and gynecologist. So make sure that if you prescribe menopause hormone therapy to that patient, you are also in the same line with your oncologist in a patient who has had a cancer already. That would be my clinical advice today.
Thank you, Serge. It's a very sensible answer, and which fixes the point quite well. Well, I see we have our very good friend, Dr. Marco Gambacciani. Hi, Marco. He points out that, well, because menopause is not a disease, the use of menopausal hormone therapy is not adequate, and he still sticks to the HRT, the traditional HRT. So it's also a very sensible point. Thank you, Marco. We have some more questions here. For example, another interesting point is Dr. Hudson raises the point of how to address women who are not within the window of opportunity. So probably I think we are speaking of women who are 60, 65, 70. These ladies are still symptomatic. And the question is, do you have any guidance on how long they should stay on low dose transdermal estrogen before considering a cautious increase if still symptomatic, increase in dose, I suppose? So, Nico, would you like to give an answer? Consider a woman who is, let's say, 65, and she's symptomatic, and well, what shall we do? Even if we start, consider the question is that we have already started with transdermal estrogen, but still some symptoms remain, so we are facing the option of increasing the dose. What do you think?
Well, yes. May I show my table? I think your question is over there. Over 60, depend of the menopause hormonal therapy. I don't agree with Marco Cambiasciani. I prefer this term, that hormonal replacement therapy. In this case, in women over 60 need menopause hormonal therapy, for example, for insomnia or vasomotor symptom. The criteria is 2, the outset, and 3 for continuation. Depend of the less or more than 5 years. Only the yellow light is for women over 70. But in this group, in women between 60 and less than 70, it's possible to use menopausal monotherapy for treating the hot flashes or insomnia. I know is you have a correct response.
Thank you, Nico. Peter, would you like to add something? You are muted.
I agree with what Nico presented, and I would just add that it all depends. The treatment should be individualized, and seeking always to see what the lady or the woman needs. If she needs treatment, and your consideration and what she wants, there always has to be like an agreement between the patient and the doctor. Like when we use a contraceptive, you can say this is the best. But she says, no, I don't want to, I don't agree. So you have to get to a consensus, and this consensus should be individualized according to each person to be treated. So I think that a woman who has risk background, genetic background, or history of some the disease should not be treated with hormones. And I would use better like alternatives, especially in women who have a history of cancer, breast cancer, et cetera, et cetera. But in ladies who are older, we published sometime women who are more than 55 who still have symptoms. Yes, they have symptoms, but the risk benefit should be evaluated per each case. And increasing the dose would not do the case, but at least continue more than 5 years it depends if the woman is starting. I don't think the woman who's 55 will go to your office and say, I'm starting, I have this for more than 5 years. I think that she would have been treated 5 years back. And then after 5 years, you would have to ask the question if she should need to continue being treated. If she doesn't have treatment, hasn't symptoms anymore, I wouldn't treat her. I would stop and evaluate what she presents. I think that that's the best way to evaluate and assess each individualized case. Antonio, the ground is for you.
Thank you, Peter. There is another interesting question here from Dr. Mustaki. So if I understand well, I read this, the combination of low-dose transdermal estrogen and IUD, like Mirena, for example, could confer less thrombotic or cardiovascular risk than systemic progesterone. Has this regimen been studied in comparison to combine oral or transdermal estrogen and progesterone in terms of safety? So if I understand well, the thing is to compare the Mirena, the IUD, with systemic progesterone in terms of thrombotic or cardiovascular risk. But then there is the addition of oral estradiol or transdermal estradiol or estrogens in general. So probably Serge, would you like to answer?
I can try to answer that question, but it's a very difficult question because there are no head-to-head trials. And if you want to answer really that question, you should have the same population randomized trial. It's not feasible because you would need too many patients to be included to give a real answer to that. So what we have is only the observational trials, and especially the most robust data, I believe, on that field come from Finland, where they had a large cohort because in that country they used actually the IUD as a progestin for menopause hormone therapy or hormone replacement therapy, which was not the case for many other countries where it was not agreed as an established treatment. Now, from what I recall, is that they had actually quite similar data, I remember that even for breast cancer, I couldn't answer for cardiovascular, but for breast cancer, I remember that they showed that there might be a very small increased risk, which was similar actually to other progestins. So you could probably not really suggest that it is the treatment to choose. Of course, if you have a patient who has had an IUD with levonorgestrel and which is still active, and you prescribe her estrogen, it should work. But I'm not sure that you really lower the risk that way.
Thank you, Serge. Would you like to add something, Nico, for example, or Peter? Okay. So, Stratios, we have forgotten you. Do you have any other question to raise to the panel?
I would like to ask the following regarding this eligibility criteria. I see that in case of colon cancer, there is no contraindication for MHT. In case of lung cancer and melanoma, the benefits outweigh the risk. I would like to ask, in case of thyroid cancer, because we know that estrogens are involved in the physiology and pathophysiology of thyroid, do we have any data, because we come across a lot of patients with a history of thyroid cancer that are in their menopause and perhaps they want to have MHT. Do we have any knowledge about this, or there is no contraindication for thyroid cancer survivors and MHT? Thank you.
Sorry, I don't understand what kind of cancer?
A thyroid cancer.
Thyroid. No, I don't know. We have only analyzed ovarian, endometrial, cervical, colon, lung, and melanoma cancer. We haven't found any study about thyroid cancer. So for the type of cancer, perhaps the criteria are similar to the lung or melanoma cancer.
Okay.
Thank you, Nico.
Mm-hmm.
I should say that we cannot stay for longer than 8 more minutes, but there's still some questions here. I'll choose a couple of them, and then sorry that we cannot continue because we don't have an option for that. There is a good question here. Can PEMIC low dose can be considered in women with diabetes? And this is from Dr. Tabassum. And there is then one clarification. The lady is under 50, and it is a type 2 diabetes. I should clarify that PREMIC is, if I am right, a combination of conjugated equine estrogens, 0.3 milligrams is a low dose, and medroxyprogesterone acetate, also a very low dose. It's a continuous combined treatment with low dose conjugated estrogens and medroxyprogesterone. And the question is if it can be used in a type 2 diabetic woman who is under 50. Serge, would you like to address this bull?
So it's a woman under 50 with diabetes treated with. Antonio, you muted.
Sorry, type 2 diabetes, yes. Type 2 diabetes, under 50, and the question is if she may use a continuous combined treatment of conjugated equine estrogens, 0.3 milligrams, and medroxyprogesterone acetate. I think it was, yeah.
She can use that, but I don't think it's the optimal regimen for her, to be honest. The lower dose of estrogen is fine, but the choice of the MPA is not the best progestin, I think. But I don't know in what country the doctor who asked the question, maybe that's the medication they have. But I would personally prefer to prescribe her a progestin that is more neutral, like progesterone or dydrogesterone, rather than MPA for her diabetes. But it's not a contraindication for sure.
Mm-hmm.
Okay, thank you. And then we have a very last question here from Dr. Tatzer. The question is, how long is active Mirena for endometrial protection in menopausal hormone therapy? Nico, please.
How long is active Morena?
The IUD Mirena. I think it's a typing error here, a typo error. Morena is not Morena, it's Mirena.
Mirena. I think it's Mirena.
Yeah.
How long is the time of Mirena effects? About 5 years.
At least 5 years.
Yeah, probably at least 5 years, because also considering probably there is also this aspect in the question, considering that Mirena maintains a certain progestational activity for longer, and the dose that we need for equilibrating estrogen is not so much in MHT, so probably even longer. Might be safe, probably 6-7 years. This is my view, but obviously we don't have
I agree.
any data about that.
We believe it's 7 years, but the manufacturer says 5 years.
Mm-hmm.
I think we have reviewed many questions about this very interesting topic obviously many more questions that could have been answered. It's time to thank again the speakers for being there, the mentees also for the very interesting questions, and also to you all for being there, Abbott for the kind support of this webinar, and the European Menopause and Andropause Society for also including this topic in the list of the webinars. We had the president, Professor Goulis, over there. He sent a message. So hello, and just remind you that the webinar is recorded, so you can find it in the EMAS website, and that you can obtain the certificate of attendance also through the website of EMAS. So I wish you a very good rest of the day, afternoon, evening, or morning, depending on where you are. And thank you again for your attention, and enjoy the rest of the day. Thank you. Bye bye.
Thank you, Antonio. Thank you, Nico.
Thank you all.
Bye bye.
Abrazo, Peter.
Oh,
Thank you.